So today I'm going to be talking about some of the work we've been doing on ensuring up-to-date predictions from prognostic models. And so with prognostic models, you can use these to provide personalised survival predictions given a patient's characteristics. And my research so far has really focused on predicting long-term survival following a diagnosis of cancer and looking at models that are developed using large population-based cancer registry data. And there's actually quite a few models which have been already developed and are all available online as really nice risk prediction tools, which are freely available for clinicians and patients. And these have all been developed using UK cancer registry data. So just to share a quick example, this is from the Predict Breast Cancer model, and you have a range of different symptoms and patient characteristics that you need to input, such as your patient's age, and the tumour size, sort of tumour grade information. And once you've inputted all of that information, it displays lots of really nice kind of infographics, so different ways to communicate the risk. And this is one that I quite like because it shows your survival probability, and it also shows the risk of death and how this is kind of comprised of the risk of death due to breast cancer and also the risk of death due to the other causes. So it sort of helps to understand the competing risks of death and sort of, I think, helps to give a better understanding about which treatments may be most appropriate for different patients. And so when you try and produce these prognostic models for long-term survival predictions, it means that you need to include patients who were diagnosed many years ago in order to have sufficient follow-up time to actually fit these models. So for example, if you want to predict 10-year survival, you need to make sure that you have patients who were diagnosed at least 10 years ago to have this amount of follow-up time. But if survival improves over this time period, then just using the standard method and not accounting for these improvements will end up underestimating survival because you've included people who were diagnosed a long time ago who have poor survival. And there's actually been quite a lot of improvements in survival in lots of different cancer sites and lots of different countries been reported. And this data comes from the ICVP study, which looks at cancer survival of 7 high-income countries. So this is for colon cancer and looks at 5-year net survival. And you can see that sort of for 6 of these countries, there's been quite substantial improvements in survival across the last 20 years. So this is really showing why it's so important to think about these improvements in survival over time and to make sure that when we fit these models, they're actually producing survival predictions which are relevant to current patients. And so if improvements in survival occur over time and we don't account for them, this can lead to what's known as calibration drift in prognostic models. So as time goes on, the accuracy of the model predictions decreases over time. And this can be due to lots of different reasons, but here we've just focused on due to improvements in baseline survival. And the EUROSCORE model is a model that's quite well known for sort of calibration drift, and it's often used as an example. And this is a logistic regression model for in-hospital mortality following cardiac surgery. And it was originally developed using data from 1995. And there was a validation study which looked at validating it using data all the way up to 2011. And they split the data up into sort of 3-month periods and then did a separate validation in each of these small data sets to really understand the temporal trends and to look at how the predictions were across time. And this is the calibration plot that they have in their paper. And if a model is well calibrated, the predicted and observed mortality should be the same. So ideally, you'd want all of your predictions to lie across this dotted reference line. But what you can see that happens for this model is that initially we're sort of slightly overestimating mortality, but as the years go on, this sort of accuracy gets worse and worse. Until the end of 2011, you can see that you might predict somebody has a mortality of about 80%, but their observed mortality is actually just around 40%. So it's almost double your predicted risk to actually what your observed risk is. And this could actually have a really large impact on sort of clinical decisions. If, for example, you have a threshold that you're using to perform surgery, you might not want to perform surgery if the predicted mortality is greater than, say, 50%. And here, because the model is so inaccurate, it's not really supporting these treatment decisions. So yeah, good calibration is really important because treatment strategies might be based on predicted risk. So for example, the surgery, there might be a cutoff where you would only consider surgery if mortality was less than a certain percentage. Also for prescriptions of statins, there's the key risk model, which looks at 10-year cardiovascular risk. And there's some guidelines which say that you should maybe think about prescribing statins if your 10-year risk is greater than sort of 7% or 10%. And because we're using these absolute risk estimates, it's really important that they are accurate and up to date. Otherwise, we might end up sort of over treating people or under treating people. And typically, external validation studies have really focused on discrimination. And in fact, the Euroscore model actually remained really good at discriminating throughout the entire period. It was really just the calibration that was overlooked. And it was really the calibration that was the issue. And a lot of the current recommendations around prognostic modelling really emphasise the importance of checking calibration. So the questions that we were looking at were, how can improvements in survival be accounted for when developing prognostic models of time to event outcomes? Can these methods be extended to other model types, so looking at competing risks or logistic regression? And then also, how can prognostic models be updated to ensure that they continue to produce up-to-date predictions? In terms of the current methods, there's quite a lot of work that's already been done on recalibration. But often when you're working with survival models with really long-term survival predictions, these methods are only usually applicable when you're externally validating data and the models, because you need to wait for another 5 or 10 years follow-up data to actually recalibrate these long-term survival predictions. So that's often not applicable in these settings. And if you do use that, it's usually like a really long time lag between actually developing the model and then having sufficient follow-up data to then re-estimate and update the model using data from new patients. There's also period analysis, which is used quite commonly in cancer registry sort of survival analysis type studies. And this has been shown to produce more up-to-date estimates of cancer survival for more recently diagnosed patients. But it wasn't typically used in prognostic modelling. So this was something that we were sort of keen to explore how that would work. And finally, modelling calendar time. A few of the papers that I looked at did consider including year of diagnosis as a potential covariate in prognostic models. But I found that this was rarely actually included in the final model. And there also didn't seem to be much thought around the functional form. So it was either included as a categorical variable or just as a simple linear term. And I think you need to be quite careful about the assumptions that you make if you're going to try and model this directly. So just to give a bit of an example, so this is looking at colon cancer data from the SEER US registry database. And just imagining that you're interested in producing a prognostic model for 10-year survival. And here we've got patients diagnosed in 1995 who might have poorer survival, but we've got 10 years of follow-up for these people. And then more recently diagnosed patients tend to have better survival, but we've only got a short amount of follow-up time for those people. And we can visualize the improvements in survival by looking at the Kaplan-Meier. So this is initially the Kaplan-Meier estimate for people diagnosed in 95 to 96. And as you can see, as I go through the more recent years, there's been quite substantial improvements in these short-term survival predictions. And then if we just did the standard type analysis and just analysed all of these people together, not accounting for any of these improvements, we end up with this sort of orange dashed line. And this is really good for summarising what your sort of average survival is in this cohort of patients. But you can see if we want to try and predict survival for patients diagnosed in 2004, it's actually not a very good estimator. And it looks like you're going to be underestimating survival by quite a bit. But this is sort of the basis of what's done usually in prognostic modelling. So I'll talk about the details of period analysis a little bit later. But this is this technique that's used quite a lot in cancer survival studies. And you can see here, if we use a period analysis technique, it actually agrees really closely with the survival of the most recently diagnosed patients. And we sort of assume that this would be a better estimate of the long-term survival of these patients. So we don't actually have any follow-up data on these patients yet, but using this technique looks like it's going to be more accurate and up-to-date. So in period analysis, what happens is we first of all define this period window. So it could be any size. Here it's a 2-year window, but it could be a 5-year window, sort of depending on what assumptions you want to make. And you then only include the risk time and events that occur during the window. So here, when I'm estimating the short-term hazard rates of 1 and 2 years, these will now only be estimated from people who were diagnosed in 2003 and 2004. So this means that they're going to be as up-to-date as possible. And for patients diagnosed back in 95 and 96, they now no longer actually contribute towards these short-term hazard rates. So they're going to be more up-to-date. But a problem with period analysis is that you reduce the sample size and number of events. So for example, this person is excluded from the analysis because they don't fall within the period window. So we have a reduction in sample size and number of events, which could be quite problematic in some settings when you're trying to develop prognostic modelling. So we wanted to try and combine the advantages of both of these methods in temporal recalibration. So we sort of proposed that you do a two-step approach where you first of all fit the standard model, and this allows you to use all of the data to estimate the predictor effects. And then once you develop your model and you're happy with that, all you then would do would be to re-estimate the baseline hazard in this period analysis sample. And you can assume that the predictor effects stay the same, and it's just really the baseline hazard and the baseline of the model which you're updating. So this provides more up-to-date hazard rates, but you still retain the sample size and all the number of events needed for the estimation of the predictor effects. So it's a bit more stable than period analysis in these small data sets. And we also considered, could modelling calendar time, could this be a good approach as well? So we thought maybe year of diagnosis could be included as a covariate in the model. And we thought maybe if we combine together the year and the month of diagnosis, it would be a bit of a smoother function. And then we would need to assess, does the assumption of proportional hazards hold? Is the trend linear? And then also, once you've fitted your model and you wanted to make predictions for new patients, how would you actually do that in practice? So imagining you've got a new patient diagnosed in 2023 and your model was fitted using data up until 21, how would you then make a prediction for this new patient? So the method we used in the simulation was just to use the hazard ratio from the last date included in the model. So for example, December 2021, and you would just assume that it stays the same. Another alternative would be to extrapolate the trend, but I think this is probably a little bit dangerous because you don't really have much data to base it on. So that's why we sort of stuck to just using the latest hazard ratio in the model. So we assessed this using a simulation study, and it's just a quite simplistic one. So we assumed that the survival times were from a Weibull distribution, and we simulated a few different covariates such as age and stage of tumour at diagnosis. And then we simulated a model development data set using patients diagnosed from 2009 to 2019, which is about 55,000 patients. And then we also had a model validation data set, which was a separate data set of 10,000 people who were diagnosed in 2019. And our aim was to try and assess the bias and the empirical standard error of the 10-year marginal survival predictions. So to do this, we use flexible parametric survival models to model our survival. So this is an alternative to the Cox model, but here you're modeling it parametrically, and you it's a bit like a Weibull model, but just a bit more flexible, so it can capture more complex hazard functions. And then we were interested in comparing the standard approach, so not accounting for improvements in survival, temporal recalibration, period analysis, and then modelling diagnosis date. And when we were modelling diagnosis date, we explored different functional forms, so sometimes using linear terms, sometimes using restricted cubic splines for non-linear terms, and then assessing whether it should be proportional hazards or if we needed to include time-dependent effects as well. And so we did lots of different scenarios. I've only really got time to present a couple today, but this is one that we largely based on the data that we had from the cancer registry data. And what we tended to find was that we got improvements in survival, and when we plotted the hazard ratios, it tended to look something like this. So effectively, there's lots of reductions in the short-term hazard rates, and it's really this which is what is driving the improvements in survival. So in this particular scenario, when we were simulating the data, we had diagnosis date as a linear term and time-dependent effects. And this is what we tended to get. And so in this graph, this is the true marginal survival. So if we had any really good models, we would hope that our marginal survival would just overlay this line. And if we just did the standard model and we didn't have any adjustments, you can see that we underestimate survival across all time points. If we use temporal recalibration, in this particular scenario, it does quite well because of how we simulated the data, because it's largely in the reduction of these short-term hazard rates. And that's something that period analysis is really good at capturing. And you tend to get very similar results with period analysis when you've got quite large data. And in this particular scenario, if you model diagnosis date correctly, you also got very well calibrated results. However, you do have to be quite careful when you're modeling diagnosis dates, because here it needs to be modeled as a time-dependent effect. But we just wanted to assess how bad would it be if we misspecified this and we incorrectly assume proportional hazards. So this is the correct functional form, but if we incorrectly assume proportional hazards, you can see that there's now quite a large overestimation in survival in this setting. So if you do go down the modelling diagnosis date pathway, you do have to be quite careful about the assumptions that you're making, and you really do need to check the data to make sure that it's plausible before fitting it, because you can end up with these sort of misspecified models and quite large amounts of calibration. And this is what we looked at when we had the results from the simulation study. So using the standard method had a bit of bias because we've not accounted for improvements in survival. If we had temporal recalibration or period analysis, we ended up with very similar results and very minimal amount of bias. So this, both these methods performed really well in this setting. And then similarly, if we model diagnostic date correctly, we also ended up with practically unbiased results. But the issue is that when I just demonstrated the slide before, if you make some incorrect assumptions and you perhaps assume incorrectly that it's proportional hazards, we can end up with these really highly biased results. And the second scenario, we relaxed this a bit further. So we now had a non-linear time trend, and first of all assumed that there were no improvements in survival before 2014. So the hazard ratio is just 1 for all of these years. And then we assumed there to be some reductions in the short-term hazard rate again. So to simulate this data, we assumed that diagnosis date was modelled using restricted cubic splines because it was a non-linear trend. And we used a simple time-dependent effect of 1 degree of freedom. So again, this is the true marginal survival. And if we just use the standard method and we didn't account for these improvements in survival, we would end up underestimating survival. If we use period analysis or temporal recalibration, again, they're both very similar in this particular scenario. We do end up improving on our predictions, and particularly in the short term, you can see there's much better agreement in this. And then with diagnosis date, on average, this produced well-calibrated results, but sometimes you do end up with these scenarios where you have overestimated survival a little bit. So just to summarize, the standard method is the most biased. Using temporal recalibration or period analysis was very similar. And then if we model diagnosis date as a nonlinear function with 1 degree of freedom, which is kind of correct based on the model that we simulated from, you can see on average the bias is small, but you end up with a really large variation. And in some cases, you end up doing just as badly as not doing anything at all. And you can also end up with some quite large overestimations. And if you have an even more complex functional form and you increase the degrees of freedom, so you're just allowing your form for diagnosis date to have a slightly more complex time-dependent effect, you can see the standard error increases even more, and you end up with even more variability in your survival predictions. So here you're having quite a large overestimation or underestimation of survival. And if you increase to 3 degrees of freedom, it increases even more. So just to show why this happens a little bit more, this is the marginal survival predictions from 1, 2, and 3 degrees of freedom for the time-dependent effects. And you can see when you have 3 degrees of freedom, something really weird happens in the extrapolations that goes on, and you end up with a really large overestimation in survival. And you can explain this by looking at the time-dependent effects. So we only have partial follow-up of these people. And so we've only got this solid line actually in our model, and then the extrapolation is this dashed line that happens once you fitted the model. And you can see there's just like this slight trend that gets exaggerated across calendar time. And when you get to 2019, there's like a really low and sudden reduction in the hazard ratio. And it's this red line which is actually used to make the predictions, which is why the survival predictions for this particular calendar year end up being so much higher. But yeah, on average, this method seems to do okay, but there's definitely a lot of scenarios that we looked at where we'd end up with these really large extrapolations that happened. And just to say that this wasn't an issue if everybody had complete follow-up time. So if you waited until 2029 and so that everybody had 10 years of follow-up and you fitted exactly the same model, we would then have really good agreement between all of them. And this is because in this particular example, we don't have to actually extrapolate the long-term hazard rates anymore. We actually have the data to estimate them directly. So we don't end up with any of these weird extrapolations that go on. So just to conclude, modelling calendar time, I think, can be a really nice approach if you really want to understand the temporal trends in survival and look at how things have changed across time. And it does do quite well if you pick the correct functional form, and if there's been improvements in the short term or the long-term hazard rates, it does tend to do quite well on average. But the disadvantages are that miscalibration can occur if it's misspecified. And so I do think you'd have to be really careful about how you assess the assumptions and how you're actually modelling calendar time. And it also does rely very heavily on extrapolation. And if you have some quite complex forms, so you're including time-dependent effects, sometimes there's these weird extrapolations that happens because you just don't have much follow-up data that you're basing it on. So to try and get around this, you might sort of say like, oh, I just need complete follow-up time for everybody in this model, but then you'd end up excluding your most recently diagnosed patients. So your model would be more stable, but you'd end up excluding your most recent people. So it would be even more out of date. Then with temporal recalibration and period analysis, in some ways these are simpler methods because you can account for improvements in baseline survival directly, but without actually modelling it. And it seems to perform well when the improvements in survival are due to decreases in the short-term hazard, which is what we tend to see with cancer data. The disadvantage is it doesn't seem to be as effective when there's been improvements in the long-term hazard. And period analysis has already been used quite a lot in a cancer setting, but potentially it may not perform as well in other applications where the long-term hazard is high. So that's something that I'm keen to explore as a further part of this work. So yeah, that's the end of my slides, if anybody has any questions.